Obstructive versus restrictive respiratory diseases are two of the most common categories of respiratory diseases you'll come across, excluding infectious respiratory diseases. So we're going to focus on what are restrictive and what are obstructive respiratory diseases, and then compare the differences between the two. So what we need to begin with is what basically happens in a healthy lung. So what I'm going to draw up first of all is a healthy lung, oversimplified. So we have a healthy lung, we have some nice open patent airways. And we know that our lungs contain a huge amount of what we call elastic tissue, because we know that our lungs need to be able to stretch out and also recall back together, as though it's filled with a huge amount of elastic bands. So we have all this elastic tissue within our lungs. Now importantly, this elastic tissue is attached to our airways. And this is important because when this elastic tissue stretches out, it needs to stretch open those airways with it. So that means when you take a nice big deep breath in and that elastic tissue stretches, it's going to pull open those airways, and then when it relaxes, they're going to come back together. Now, we know that when our lungs need to expand, we need to do this by contracting predominantly what we call the diaphragm, which is the muscle that sits underneath the lungs, and also the external intercostal muscles, which are the muscles that sit between our ribs. Now, before we talk about that, you need to know that the lung itself has some membranes associated with it. There's a membrane that's most adherent to the lung tissue itself, and this membrane is called the visceral pleura. And there's also another membrane that just sits a little bit away from this, further away from the lung tissue, but closer to the rib cage, or the thoracic cavity, I should say. And this is called the parietal pleura. So there's two membranes, visceral pleura and parietal pleura, and in between there's a fluid that's released, and this fluid, what happens is this fluid allows for some lubrication to occur, but also there's a negative pressure inside of this little cavity here called the pleural cavity. Now, this parietal pleura is going to be adherent to the thoracic wall. So what we're going to draw up now is some ribs. Now again, I'm oversimplifying this. These ribs are going to be a little bit closer than what I'm drawing. And also between those ribs, you're going to have some muscle, which is going to be the external and internal intercostal muscles. Now, I said there's going to be a diaphragm, so let's draw the diaphragm in, which is that nice skeletal muscle that sits underneath the lungs itself. So you know that when we need to take a breath in, what happens is, because we have a negative pressure in this pleural cavity, it's like a vacuum. What happens? They stick together. And because they stick together, whatever this parietal pleura is attached to, the visceral pleura will move with it as well. So because this parietal pleura is going to be adherent to the diaphragm and also to the thoracic wall, if the diaphragm moves down, which it does when it contracts, it's going to pull the lung tissue with it. And when the external intercostal muscles contract and the rib cage comes up and out like this, it's going to pull the lungs with it. And so that's what happens when we take a breath in. Diaphragm goes down, external intercostals pull outwards, and the entire thoracic volume increases. And when that entire thoracic volume increases, it becomes a little bit negative in here and air rushes in. Now, what tells these external intercostal muscles and the diaphragm to contract? Well, it has to be some sort of nervous innervation. Where does this nervous innervation come from? Well, it has to come from the central nervous system. So let's draw up very quickly the brain. I'll draw it the other way. You're going to have the brain, the cerebellum. You're going to have the midbrain, pons and medulla of the brainstem. Then we're going to have the spinal cord. So yes, it's an oversimplified version. Now, when it comes to respiration, the most important area of the central nervous system is the brainstem. Specifically, it's going to be the So remember, you have the midbrain, the pons, and the medulla, which make up the brainstem. The respiratory center is made up of the medulla and the pons. Okay, so the medulla and the pons are the most important aspects of the brainstem for respiration. We're not going to go into the specifics of it, but just know that there's neurons there that help you breathe, and that these neurons are going to talk to neurons of the cervical plexus and of the thoracic nerves. So as we move down, we're going to go to the cervical region of the spinal cord, and we're going to talk to three aspects. So C3, C4, C5. C3, C4, C5. Now these neurons what they do is they innervate the diaphragm. So neurons from C3, C4, C5 come and innervate the diaphragm, which means they tell the diaphragm to contract, which means it pulls down and that air comes in. So inspiration. This nerve, as you know, is called the phrenic nerve. C3, C4, C5. We've also got some coming out of the thoracic aspect of the spinal cord. Now I'm not going to draw the adequate number, but I'm just going to draw some just to highlight to you. And these are going to innervate the external intercostals, which then tells them to contract, and therefore bringing the rib cage up and out, and again allowing air to come in. So this is part of the normal anatomy for the respiratory system. Why am I telling you this? What does this have to do with restrictive and obstructive diseases? Well, so remember, lungs need to expand. That's what needs to happen normally. Now, they need to be stretchy, so it's called stretchability, but we don't call it clinically, we don't refer to it as a stretchability. Stretchability we call compliancy. So let's just write that down. Compliancy is the stretchability of the lungs. How stretchy the lungs are. Now, if it's very compliant, the lungs can stretch out quite easily. And remember, we need it to have a nice elastic recoil as well. Now, if something happens, doesn't matter if it starts at the central nervous system, doesn't matter if it comes from the peripheral nervous system, doesn't matter whether it comes from the musculoskeletal system, doesn't matter if it comes from within the tissue of the lungs itself. If something happens to restrict the expandability of the lungs, that is called a restrictive disease. So restrictive disease limits lung expansion. Okay? So restrictive diseases limit lung expansion. And as you can see, that can come from the central nervous system, peripheral nervous system, musculoskeletal system, or within the tissue itself, also known as within the parenchyma of the lung. So, if we were to look at all the causes of restrictive diseases outside of the lung itself, that's known as extrinsic restrictive diseases. They're known as extrinsic restrictive diseases, also known as extrapulmonary diseases. Okay, extrapulmonary restrictive diseases. So if it comes from the central nervous system, an example of this could be amyotrophic lateral sclerosis, ALS. In the States, it's known as Lou Gehrig's disease. And this is going to be neuronal degeneration of the central nervous system, which can affect, obviously, the neurons that innervate the external intercostal muscles and the diaphragm. We can have issues in which we have damage to these nerves, either in the spinal cord itself or the peripheral nervous system, and this can happen through spinal cord injury, for example. You may get depression of activity of these neurons within the central nervous system, and this comes from morphine, for example. We know depresses the respiratory function and can depress patients' respiration as well. What else can we have? Well, we can have issues with the muscles of the respiratory system, and this is what was common in polio, hence why individuals who had polio needed to breathe inside of what was called an iron lung to sort of recapitulate what happens normally when lungs expand. That's what that machine would do, expand the chest cavity for you. Or we can have issues with the bones or skeleton of the respiratory system. What's the most common aspects there? Well, we've got the ribs and we've got the spine. Why the spine? Because the ribs are attached to the spine. So if you have a broken rib, you know it's very difficult to breathe, or at least it's quite painful to breathe. Or if you have a problem with your spine, meaning you have some sort of kyphosis or scoliosis or lordosis, which are abnormalities of the curvature of the spine, well, if the spine's going to be curved, whether it's going to be lateral curvature abnormalities or anterior posterior curvature abnormalities, this is going to alter the way that the ribs are positioned and also alter the way that you can breathe. So these could be classified as extrinsic restrictive pulmonary diseases. Okay? I want to focus on intrinsic restrictive pulmonary diseases. So what's happening inside the lung tissue itself? So in order to do that, let's get rid of some of the stuff we've put up at the moment. And we're going to focus just on the lung tissue itself. Now, as you can see, we've drawn up a nice, healthy lung here. We have nice patent, which means open airways. We have a lot of elastic tissue, which you can see here. This elastic tissue allows for the lungs to be compliant, which means stretch out, but also very importantly, allows for the lungs to recoil. Okay, so that's very important. It allows for the lungs to recoil back in. Now, when you breathe normally, I'm sure you've already had a look at what we call pulmonary function tests. So that's where you breathe into a machine and it looks at your tidal volume, which is your normal breath in, normal breath out, your inspiratory reserve volume, how much breath you can take in when you forcefully inhale, and your expiratory reserve volume, how much air you can forcefully exhale. And you also know that you cannot ever exhale every single bit of gas inside of your lungs. That's important because one, don't want your lungs to collapse. Two, even when you want to exhale all that air out, there needs to be some gas remaining for gas exchange with the blood. Okay? So, nice, happy, healthy lung. Let's just draw up a nice pulmonary function test just to represent what's going on. Well, like I said, you're going to take a nice tidal breath in and out, and in and out, and in. And then you know that after a normal breath in, you can breathe even more air in. This is called the inspiratory reserve volume. And you know that you can breathe that out. And you can try and breathe out as much of it as you can, called the expiratory reserve volume. And then you go back and you take another nice tidal breath in, out, in. Okay, so what we've got, a couple of things we need to highlight. First thing we need to highlight is, like I said, this is our tidal volume, TV, it's often referred to as. Breath in, breath out. We've got the inspiratory reserve volume, the IRV, how much air we can breathe in on top of a normal breath in. The expiratory reserve volume, how much air we can breathe out on top of a normal breath out. And like I said, you can't breathe all your air out. You've got a residual volume. Now that means that at the bottom of this residual volume is going to be 0 liters. This is when your lungs do not contain any air at all. So let's just draw a nice line because I want to compare this between restrictive and obstructive diseases. So let's draw a nice line across the entire board. Hopefully it's nice and straight for you. And like I said, this is going to represent 0 liters. Now, normal, nice, happy, healthy lung. When we look at intrinsic restrictive diseases, something has to happen inside the lung parenchyma itself to restrict the expandability of the lungs, right? Because that's what a restrictive disease is. Now, what can happen is this. If over time, so chronic exposure to irritants, some sort of particulates, some irritants to the lung tissue, it can damage the lung tissue and lead to scarring of the lung tissue. Now, this is called pulmonary fibrosis. Pulmonary fibrosis, which literally means lung scarring. Now, because you're having irritation and you're having damage, you know that when some sort of inflammatory response occurs, that quite often Damage to this tissue will lead to scarring, so more collagenous tissue, so more collagen fibers will be deposited. And so what you're going to get is more tissue being deposited. Let me leave that as a normal, happy, healthy lung, and I'll draw up a new lung up. I'm intentionally drawing it smaller, and I'll tell you why. Firstly, when we look at restrictive diseases, the airways are of normal size. I'll tell you why in a second. But like I said, you've got a greater amount of collagen deposited and sometimes even more elastic tissue, so it's very, very dense inside the lung tissue itself because of this pulmonary fibrosis. So more tissue is being deposited. Now, what does that mean? Well, think about it. If we think of the normal, happy, healthy lung as being, let's say, 10 rubber bands, let's write that down. Just write 10 rubber bands. If you had 10 rubber bands together and you were to stretch it open, it would have some sort of stretchability or compliancy to it. And then if you let go, it would have some level of elastic recall to it. That's a normal, happy, healthy lung. You can think of the restrictive lung as having, let's say, 20 elastic bands or 20 rubber bands, however you like to refer to them as. What does that mean? Well, if you had 20, it's going to be a lot harder to stretch out because you've got more of them, but they'll have a very high degree of elastic recall. So that means the compliancy is reduced, but the recall is increased. Let's write that down. For restrictive diseases, compliancy is decreased and recall has increased. So that's why the lung's smaller, because it's hard to stretch it out, but at rest it's quite tight. It's recalled quite a large amount because of all these fibers that are deposited. Okay. Now, what do you think that means if we look at this pulmonary function test? Well, you're going to have a relatively normal tidal volume, but do you think you'll be able to forcefully inhale that inspiratory reserve volume as well as you can with a healthy lung? No, it's going to be very difficult. So you're going to have a reduced inspiratory reserve volume because it's hard to expand those lungs. If the inspiratory reserve volume is reduced, that means less air in. That also means less air can come out. So your expiratory reserve volume is reduced as well. Now, in addition to that, if the lungs at rest are smaller, there's going to be less air remaining in there that you can't expel, which means the reserve volume is also reduced. So if we were to draw this up, we would have a relatively normal tidal volume. The inspiratory reserve volume is going to be low, the expiratory reserve volume is going to be low, and the residual volume is going to be low. So you can see tidal volume's not too bad. Decreased expiratory reserve volume. Inspiratory reserve volume. Decreased expiratory reserve volume. And you can see decreased reserve volume. So we can write that up here. You have decreased inspiratory reserve volume, decreased expiratory reserve volume, decreased residual volume, and overall, if you look at total lung capacity, well, that's the total lung capacity there, you have decreased total lung capacity as well. This is what you commonly find in restrictive diseases. Let's look at obstructive diseases. How do they differ? Well, restrictive is some sort of difficulty in expanding the lung tissue. Obstructive is some sort of obstruction in the airways. So here are the airways. Now, there's a couple of common obstructive diseases you need to be aware of. These common obstructive diseases include asthma. That's one. Now, in asthma, we're going to have a number of other videos available to you that discuss asthma and the following, so I'm going to be very quick in the way I describe it. Asthma is a reversible disease which involves narrowing of the airways. So what you find is that if you have a normal airway, in asthma, it's narrowed. Now, this narrowing of the airways is often due to hyperresponsiveness. Which means something that in somebody who doesn't have asthma wouldn't trigger any constriction of the airways would trigger it in an asthmatic patient. So hyperresponsiveness doesn't usually affect others, but only affects those individuals who have asthma. And it's a narrowing of those airways. And it can be due to a number of reasons. You can have extrinsic and intrinsic causes of asthma. Narrowing of the airways, hence it's an obstructive disease because it's obstructing the amount of air that can go in and out. Another common type is chronic bronchitis. And in chronic bronchitis, you have some sort of irritation, chronic irritation, that causes mucus hypersecretion. Mucus hypersecretion. So what does that mean? It means this irritation is causing more mucus to be secreted within the airways. And so what are you going to have? You're going to have your airway, and you're going to have mucus inside of that airway. And again, that mucus will plug these airways up and obstruct the airway, hence why chronic bronchitis is an obstructive pulmonary disease. The last one is emphysema. And emphysema, yes, you have some sort of obstruction within the airways, but what happens as well is that 80 to 90% of patients who have emphysema have a history of smoking. What happens with smoking is that these particulates, these chemicals that are coming into the airways, start to damage the lung tissue itself. And in addition to that, we have macrophages, remember, big eaters inside the lung tissue, which are trying their hardest to rid the lung tissue of these invading chemicals, these chemicals that shouldn't be in here. Now, they secrete proteases, which are enzymes that break down proteins, and elastases that break down the elastic tissue within the lungs as well. So what that means is, apart from obstructing the airways in emphysema, you also have the elastic tissue within this airway being eaten away as well. So what does that mean if I were to draw it up? If you were to remove some of this elastic tissue, think about what that means. Remember I said 10 elastic bands here, 20 elastic bands for restrictive. With obstructive, you can think of it as though there's only 5 elastic bands. That means it's a lot easier to stretch open, but the recoil isn't as great. So that means you have a high compliancy, but a poor elastic recoil, which is pretty much the opposite of the restrictive. So if we were to draw up a lung of somebody with an obstructive disease, the lung is going to be larger, and the airways are going to be smaller because it's an obstructive disease, and the elastic tissue is going to be reduced. Again, what does that mean? It means that when you pull on this lung tissue, it's going to be quite stretchy, just like you would with about 5 rubber bands or elastic bands. Opens up very easily, but doesn't snap back very well, which means that patients with obstructive diseases, particularly asthma, chronic bronchitis, emphysema, which we commonly refer to together as COPD, chronic obstructive pulmonary diseases, it means that they usually don't have a big issue with breathing in because it stretches very easily, but they have a big issue with breathing out. And it's very difficult to get all the air out of their lungs. So this means that breath in, breath out, they don't exhale as much as they should be able to exhale. And that means that, what do you think? Their respiratory volume is going to get greater and greater. The amount of air that they can't breathe out increases and increases and increases. And this is commonly why you see some of these patients with a big barrel chest. Quite common in individuals with emphysema. So if we were to draw this up again, what you're going to find, and I have to rub this out a little bit because I'm going to go a little bit higher, is that I said the residual volume is higher. The tidal volume is going to be not too bad. The inspiratory reserve volume is going to be quite high. The expiratory reserve volume is going to be quite poor. And the residual volume is going to be quite high. So increased inspiratory reserve volume, increased reserve volume, decreased expiratory reserve volume. And what about the entire total lung capacity? Increased total lung capacity. So comparing compliancy and recall, might as well write it down. The compliancy for an obstructive disease is greater. The recall is reduced. Okay? And again, you have increased total lung capacity, increased inspiratory reserve volume, increased residual volume for somebody with an obstructive disease. Remember I said that this elastic tissue is attached to the airways? That means that when you expand a lung, the airways get larger, and then when you bring it back together, the airways get smaller. Think about what happens with an obstructive disease. I said that they can easily stretch their lungs out, which means the airways open up. But because there's reduced elastic tissue, not as much of this elastic tissue is attached to the airways as there should be, which means that when it comes back together, the thing that keeps these airways open and patent is their attachment to the elastic tissue, which means people with obstructive diseases, when they go to breathe out, the airways are likely to collapse, because the thing that keeps them open and patent is that elastic tissue, and there's not much there. So it's quite common that they have collapsing airways, which is one of the reasons why you see patients with emphysema breathing with pursed lips, because if they were to exhale too quickly, the airways can collapse. So they control the expiration through pursed lips. That's the difference between restrictive, just very basically the difference between restrictive pulmonary diseases and obstructive pulmonary diseases.